takes a lot more HCG, wouldn't it, to get a similar amount of elevated testosterone levels as would.
And then after 2 weeks, they feel a great kick.
The cost involved having testosterone and HCG can sometimes be more, but
if you increase the dose, you feel lousy, you have retinopathy, blurred vision, and also
actually, because you're using a smaller dose of HCG,
the sooner they clears the system, so it's counterproductive, especially in large doses through the intratesticular testosterone, and HCG improves fertility.
You know, similar to dosing, what's going to be best for the individual patient? And I think it's a way up of cost, convenience, what's available in your country. Testosterone propionate of the Sustanon mix is the lowest level. I think it's quite misunderstood. I think in the UK, Australia, other countries throughout the world, the Netherlands, other parts of Europe, there's Sustanon, but there's also Omnidrin, which is
Omnidrin in Poland, yes.
But it's exactly the same formulation now as the Sustanon.
I think there are 3 blends in Omnidrin.
4. It's the same. It's the same exact combination as Sustanon now. That's a good question. So how long does HCG take to increase intratesticular testosterone?
While on TRT?
Let's say, as a monotherapy. So they just did HCG alone. Now, you know, the experience why HCG isn't used alone.
Monotherapy, but it shuts off the LH.
Yeah, it shuts off your LH. So there's really no advantage when you compare it to testosterone, other than you keep your testes going. But it takes a lot more HCG, wouldn't it, to get a similar amount of elevated testosterone levels as would an injectable testosterone. So you can do 100 milligrams every 5 days with testosterone cypionate. It may take, I don't know, 500 IU of HCG about every other day, maybe to get it close to the levels that you would reach with the injectable testosterone. What do you think?
Well, when we use HCG as a part of the PCT protocols in bodybuilders, we use it every 3 days, that's the half-life. And I'm telling them to use 5,000 to 6,000 IUs. And then after 2 weeks, they feel a great kick in libido, in mood, even in strength. So after the second week, they feel the difference.
5,000 to 6,000 IUs?
Totally.
Totally.
So divided 5 doses PCT. Or 6 doses of 1,000.
Okay.
So we do kind of a small dose, micro dosing, every 3 days.
About 500 IUs?
2,000.
2,000 IUs?
Every 3 days.
Every 3 days.
Yes. And during the second week, they feel the difference.
Okay, so it does bring up but it's a lot of HCG to use.
I wouldn't compare apples with oranges. I mean, it's like comparing a knife with a gun. I mean, testosterone is the real deal. It cannot be substituted by anything. Mm-hmm. Now, bring them together, if they join HCG, it's much better also. Because you don't shut off your own production, your balls are still alive. And also it's a libido enhancer during TRT because this intratesticular testosterone will give you more sex drive.
Well, not to mention that if you have the cost involved, having testosterone and HCG can sometimes be more, but if it's actually, because you're using a smaller dose of HCG, it's not as cost prohibitive as if you had to use a massive dose of HCG.
I'm doing actually 100 IUs every day. I break it down as Chrysler used to say, John Chrysler, that mimic your own production of testosterone with small doses of HCG.
One type of person that couldn't use HCG would be those who have testicular damage. Right? If you're primary hypogonadism,
or perhaps seminoma, testicular cancer survivors.
Yeah, because then there's not a whole lot to produce.
But you believe that in testicular failure in primary hypogonadism, HCG has no benefit?
I think that's very little. If your testes aren't going to take a signal from your LH, which is better, and FSH, why would it do any better with HCG? Enanthate is more estrogenic than Cypionate.
No, actually, it remains in the system 4 days, 5 days, while Cypionate 8 days. Therefore, there are more chances of Cypionate to aromatize. The opposite. The sooner it clears the system, like Propionate, for instance, it doesn't aromatize.
They're nearly identical.
It's 71 to 68, but if you search out the half-lives, it's 5 days to 8 days. And also aromatization is up to the dose, okay? Also,
exactly. How much dose?
Adipose tissue, ethanol, soy, okay?
Well, probably your first step is try to get, the one thing I've heard from some doctors is just increase the total dose, but there are still some men who may not convert, and we've seen this. It's rare, but we've seen it a few times.
I would add HCG. HCG.
You'd add more HCG. And then if that didn't work, a synthetic estrogen.
Yeah.
Or bioidentical estrogen probably is a cream. And they do make estradiol injections as well, but maybe a little bit of cream to help with that.
It's counterproductive.
Well, clomiphene.
It works in the paper, but it raises LH.
So
Total testosterone, SHBG, and free testosterone goes down. So it's counterproductive, especially in large doses. Crystal said 12.5. In very low, it may work. But if you increase the dose, you feel lousy. You have retinopathy, blurred vision. And also, it's...
Well, the issue with some like Clomid is it agonizes the estrogen receptor. So it's going to be affecting the liver. You're going to, you're right, raise SHBG. You have some pro-estrogenic effects, and then you're going to have some anti-estrogenic effects in the brain. So Clomid is a tricky one because not everyone feels
And also
better
they
on
trigger
Clomid.
clotting, the SERMs, huh?
Yeah, and potential clotting with SERMs, yeah. One of Dr. Mark Gordon's programs for TBI, he is a big proponent of Clomid. Remember Dr. Mark Gordon? For those who had traumatic brain injury, he was using a clomiphene to help stimulate the brain, plus adding a bit of testosterone into the mix, no more than about 60 milligrams.
I would say HCG is superior to Clomid, to the side effects, and to the efficiency in the testicles.
Well, I think people subjectively feel better with the HCG or exogenous testosterone than they do with Clomid. Estrogen, high estrogen, increase the chance of infertility in men.
Now, usually the high estrogen shut off GnRH for LH.
Yeah, it's part of the feedback loop.
Yes, yes. And in such case, you have less testosterone that matures the sperm. In 90 people, okay? Now, in 90 people, this way. Now, in people within replacement therapy, estrogen is beneficial, okay? We shouldn't block it.
Of course. So is it TRT, HCG, and will the increased HCG, which causes increase?
I guess not, because HCG increases estrogen through the intratesticular testosterone, and HCG improves fertility. I wouldn't say a negative factor of estrogens during the fertility, because this is what HCG does.
Well,
Indirectly,
testosterone increases, estrogen increases.
It depends on the lifestyle somebody wants to use. Okay, if he wants to do, if you want the perfect microdosing, I would say is the cream.
For doing
The lesser spike. Okay. If somebody travels a lot and is not convenient with injections, okay, do it with anticonate every 8 weeks, I would say.
But for the general population, I mean, we've seen in some of the...
If I had propionate in my country, I would use propionate to avoid the spike and elevate my SHBG.
SHBG.
My SHBG, yes.
I think we see, at least in the UK, quite a large number of patients using Sustanon in varying degrees every 5 days, similar to the Cypionate. And I found personally, when I switched from Cypionate years ago, when I was in the States, to Sustanon, it was nearly a 1-for-1. But I've done as well as...
Have you tried the Greek Enanthate?
I've tried the Greek Enanthate, I've tried the different Cypionates. Yeah, they're very comparable. When I didn't have my Sustanon and the Greek Enanthate was there when I was in Greece, I didn't miss a beat. I used the same exact dosage I was doing with Sustanon, with Enanthate. I didn't notice any difference with either of those.
It comes in 200 or 250?
It comes 250, one of the brands in an ampule, 250 in 2 mLs of olive oil and ethyl oleate. So it's a combination of mostly olive oil and ethyl oleate. And that's made in it. Well, it's licensed in Spain by an Italian company. It's also made in 100 milligrams in 2 mLs. But there's a 250, 100 milligrams in 2 mLs. From the United States, there's 2,000 milligrams in 10 mLs, and there's 1,000 milligrams in 10 mLs. So these are the different options that are available mostly throughout the world. I know there's a few other ones. So what is the optimal one? Similar to dosing, what's going to be best for the individual patient? And I think it's a way up of cost, convenience, what's available in your country. And I think that, for me, I've got a choice between all of them, and Sustanon seems to be one of my favorites with that one. But again, it just depends on what works for most people, and what we've seen is that seems to be working the best, but there are many other options that we have, especially at our pharmacy. Okay. On paper, and for some people, subcutaneous seems to work well. The question is, and what do they consider subcutaneous. So the Chrysler, he kind of popularized Dr. John Chrysler. He has this video of him looking quite buff and tanned, and he goes into the fat pad in the stomach. Now, when I was younger, and some of our patients have also tried it, and I've got pictures of people in our Facebook group that sent me the result of them doing the subcutaneous injection. What we've seen are these lumps and bumps and bruises, and the bruises, they last for weeks.
You have to know that the blood supply into the subcutaneous area is much poor.
And that's the other reason.
It's slowly absorbed the day after, I guess. And also, if you inject, of course, oil into the fat, you create the lumps, especially if you are lean.
So, right, that's not a very nice
Unlike the intramuscular, the shallow intramuscular, as Virgil says, into the delts with an estrogen series that goes straight to the bloodstream and is absorbed abruptly.
Well, essentially, yeah, and that's what I love about Dr. George's compromise is that it is a compromise. So for some guys, they're fearful.
It was for the sake of the scar tissue initially by Chrysler.
Yeah, but here's what we've heard from some of the other doctors on our channel is that you still get scar tissue with subcutaneous insulin. If you're injecting over
to a mark, it doesn't hurt that much.
But you can get subcutaneous scar tissue if you're injecting, so even water-based HCG, growth hormone, peptides.
I have to admit that with HCG that I'm using on a daily basis and GH, I have some lumps.
So there you are. So this thought about
and you can see this in bodybuilders
scar tissue.
When they do the abdominal pose because they inject insulin into the stomach and GH. They have these lumps because they are very thin, the skin.
And they're creating maybe scar tissue. So where the muscle, if you inject into the muscle, it's got more blood vessels, so less chance of it forming scar tissue.
More recuperation, eh?
Yeah, more chance to recuperate, more chance to heal. So that was from Dr. Kathy Smith O'Neill, who's been on the channel. She acknowledged that. So where I love your compromise is this. For those who are afraid of the extra long needle on top of the syringe and all that goes along with it, some people are fearful of that needle, but they're not as fearful of the small subcutaneous injection, or the insulin syringe, which is an all-in-one needle and syringe together.
27 gauge, I think.
Oh, 27. I think 27 gauge is quite good because it's large enough to accommodate the oil. So if you do it in a thin in an area like the quads or the delts, then you're going to essentially do an intramuscular.
You penetrate all the muscle.
Yeah, you're going to do an intramuscular injection, but you're not going to have all the lumps and bumps that you normally get from that subcutaneous injection, especially when guys want to put it right in the abdominal fat. And again, like you said, the other benefit of going intramuscular is one, it says it right on the label. If you ever see Cypionate, testosterone Cypionate, it'll say for intramuscular use only. Right? So why would you put it subcutaneous? If you're afraid of needles, most of the pain is in the is in the initial layers of the skin. Once you get through the skin and into the muscle, most of the hard work's been done already. Most of the pain you've already been through it. So once you can get yourself convinced to go into the muscle, it's not that bad. Now the degree and how deep you go will depend on whether you use an all-in-one insulin syringe or you use a 23, 25 gauge needle to do the injection. And there are some techniques where you change out the needle and do a smaller needle. So you would maybe withdraw with, if it's an Ampion 18 gauge needle with a filter on it, and then you would swap it out to a 25 gauge needle for the actual injection. So now it's very sharp, or even a 23 gauge needle where if it accommodates that really, really viscous oil and you don't have to push as hard. So you have less pressure there.
The SERMs elevate, they kick the brain, that's why they elevate the LH and FSH. Yep. And afterwards, LH and FSH kick the testicles for the Sertoli and the Leydig. So indirectly they kick the brain, and afterwards they kick the testicles. That's what SERMs do.
But when you discontinue it, it will normalize it.
Yeah, I guess so.
In time, I mean, if you're once that, because essentially the SERMs
I've seen
are
in the
blocking
paper
the brain. Yeah.
Men that doing the PCT protocol, and right after, the week after, it's still elevated. I've seen LH of 10, for instance.
Right. Oh yeah, I've seen quite high LH and 10, FSH 15, as well.
Yes.
And we've seen some success stories with patients who have used
Could
Clomid.
Be temporary. They rise and fall again.
Yeah, and I've seen that before with some patients that had used they try to
feel
recover.
Good, but temporary. After a while, they go down again.
Yeah, it's usually because of the racemic mixture of Clomid, right? So you got the two different there's Clomifene and Clomifene, and the N-Clomifene is more anti-estrogenic, and the zooclomifene is more pro-estrogenic, but the zooclomifene lasts longer in the body than the N-clomifene.
Tricks the hypophysis.
If you like content like this, do click like and subscribe and hit the notification bell if you want to get our latest updates for when we drop content. It really does mean a lot. And until next time, to your wellness, this is Mike.